Respected chairpersons, the audience, ladies and gentlemen, I welcome you all on my today's presentation on shedding of COVID-19 virus in tears and conjunctival secretion in a pandemic situation. Myself, Brigadier General Kamrul Khan, I am working as a HOD in the Combined Military Hospital, Dhaka. I don't have any financial conflict. These are the staffs. I acknowledge their contribution, staffs of my department, the pulmonologist, the microbiologist, and team Combined Military Hospital. Background of the objectives: in December 2019, an outbreak of novel coronavirus COVID-19 emerged in Wuhan, China, and has quickly spread throughout the world. Novel coronavirus strain may produce conjunctival inflammation and can be detected in tears and conjunctival secretions. Coronavirus had been previously reported to be associated with conjunctivitis in humans. Retinal disorders such as retinal vasculitis, retinal degenerations, blood retinal barrier breakdown had been demonstrated in experimental animal models. And implications in that is that there may be a potential hazard to the healthcare workers, especially the ophthalmologists who perform examinations in close proximity to COVID-19 patients and may come in contact with the tears and conjunctival secretions. COVID-19 is a highly contagious disease capable of progression to acute respiratory distress syndrome, even death. The infectious agent of this disease entity is caused by a novel coronavirus, severe acute respiratory distress syndrome coronavirus, that is SARS-CoV-2. In March 2020, the first case of COVID-19 was detected in Bangladesh, and day by day it had been increasing. Along with the nasopharyngeal swab, conjunctival secretion may also become a spread of source of infection, and it may be potential route to transmit to other people also. So we undertook this interventional study to examine conjunctival swab for presence of SARS-CoV-2 RNA and determine whether a correlation existed between systemic COVID-19 infections with shedding of it through the conjunctival secretion. Ocular complications of SARS-CoV-2 infection have not been widely reported. Viral loads in ocular tissue are still to be investigated. In our country, the number of COVID-19 patients are growing almost alarmingly high. So conjunctival diagnosis may be a tool for early detection and better planning to stop transmissions through population chain. Currently, our understanding of possible ocular complication of SARS-CoV-2 infection is very limited. A retrospective study tested conjunctival samples for SARS-CoV-2 RNA in 30 infected patients, and conjunctival samples were from one patient were positive for the virus on third day. The fact that their patients developed acute viral conjunctivitis with positive SARS-CoV-2 tests in conjunctival swab samples indicated that SARS-CoV-2 could indeed cause complication, but not necessarily in the same stage of the illness. Zhou Y et al. Described in their study that of 121 patients with confirmed COVID-19, 63 patients had mild or moderate disease. 53 patients had severe or critical disease. The mean standard deviation of the duration of the disease was 15 days. 8 patients showed ocular symptoms. Only one of them showed positive results for SARS-CoV-2 in the conjunctiva. Wu P et al. Described they have recruited 38 consecutive patients with COVID-19 positive. 28 patients had positive findings for COVID-19 on RNA-PCR from nasopharyngeal swab, and of these, 2 patients yielded positive findings. Conjunctival swab specimen remained positive SARS-CoV-2 on 14th and 17th days after onset. On day 19, RT result was negative. Chen Lu et al. Narrated a case report with slit lamp finding. Slit lamp examination revealed bilateral acute follicular conjunctivitis, but they don't find any RT-PCR positive in conjunctival secretion. Our patients, our type of study was a prospective interventional study. Place was Combined Military Hospital, Dhaka. Period of study was May 2020 to June 2020. Study population: confirmed COVID-19 patients admitted in corona-dedicated ward of Combined Military Hospital, Dhaka. The patient with COVID-19 positive, age between 1 year to 90 years, and the exclusion was patients with a history of pneumonia, tuberculosis, COPD, uveitis, and history of recent ocular allergy. This patient was excluded. But for infrastructural key constant, only 20 eyes was included in the study. Sampling technique was randomized and non-purposive. Patient under study was explained in details about the disease process, benefits of evaluation, and methods and risk of evaluation technique. Written consent was taken, maintaining the principle of health. A total of 20 eyes of 20 patients randomly was selected, and unfortunately or fortunately, we did not find any single positive cases of COVID-19 from the nasopharyngeal swab. In presence of SARS-CoV-2, RNA was detected by real-time RT-PCR in Armed Forces Institute of Pathology and maintaining all the protocols of international review. In none of the cases we find the COVID-19 positive. There was no positive cases. COVID-19 illness can range asymptomatic to mild to severe respiratory distress. An ophthalmologist was first to report the virus in Wuhan. Himself contracted and succumbed to death. Ophthalmic manifestations are varied in terms of presentation, severity, and timing. So, shedding of COVID-19 virus was not found in tear or conjunctival secretion. Still, protection is essential due to unknown extension of the corona effect. Proper safety and protection with scientific protocol will help to continue daily essential activities. Thank you very much. These are the references.
Thank you, Dr. Abdul Khan. Do we have any questions?
Yeah, I have
sorry, go ahead.
Sorry. Now, I have a question. In fact, a couple of questions. What was the type of randomization? He said that Dr. Khan said that the randomization was done. So how was the patients randomized? And secondly, what was the time gap between the RT-PCR positivity by throat swab and the conjunctival swab?
Thank you very much for asking the questions. Actually, we decided to go for initially a big number of cases to be tested, but I have already mentioned due to time constraint and as well as the constraint of our kits, we ultimately restricted only 20 patients. But we did not go for any particular specific type of patient. We have just taken the sample who are COVID positive and admitted in the hospital, and we usually took the sample twice. First, just after admission in the hospital, we have taken the nasal sample, and after 7 days we have taken another sample. This was our study system.
The question that I wanted to ask you was that in your study, the patients who were negative in the conjunctival and the teardrop study and were positive in the RT-PCR study, how many of them actually turned out and went to a stage where they needed to go on a ventilator or something like that? Was there any correlation between the severity of conjunctivitis and the patients who went on ventilator?
Actually, this study, some of the cases there was no at all conjunctivitis. We just studied only those patients who are COVID positive, admitted in the hospital. We have taken sample whether there is any COVID-19 virus present in the conjunctival tears or secretion or not. Just only.
You showed slides of patients with conjunctivitis, conjunctival congestion.
Yes.
That's why I asked this question.
Yes, few of the cases we found conjunctivitis and not related even with this study. We get some of the cases who are not included in our study. We have shown the slide that COVID-19 positive patients has reported to us with conjunctivitis in different forms, with a mild varieties up to a very severe one. But in our study population, among those 20, only 2 patients we had conjunctivitis, and that was only of very mild form.
Thank you very much, Doctor. Welcome to AIOC. Enjoy the conference.